heard of the term pulling the plug.
Correct.
Yeah, and I would like you, Doc, to please elaborate on that, because I think for most families who can afford this life support system, they are very hesitant in pulling the plug.
Correct.
So when should the plug be pulled away from the patient who is already dying?
Okay. So normally, if a patient's condition is such that she's having a difficult time breathing on her own, then that's when we call it intubation. We put a tube here in her mouth. That tube goes all the way here, and then so that it enters the lung, and then artificially oxygen will be blown into her lungs by the machine. So that's mechanical ventilation. No? So now, usually, if the condition is just acute, like a pneumonia, you have stage 4 cancer, but at the same time you had a pneumonia, something acute. You didn't have pneumonia before, now you have pneumonia. It's an infectious disease. So normally we have a whole range of antibiotics that we can use on the patient. So you might say after 7 days of treatment, 14 days of treatment, the pneumonia will be cured already because it's something acute and reversible. Then logically, we should be able to take out the tube and remove the mechanical ventilator. So we call that natural weaning from the mechanical ventilator. Unfortunately, many things happen in the course of the illness of the patient, and there are some cases where the patient will not be able to breathe without the mechanical ventilation. So after 2 weeks, normally we shift from a tube here and down their mouth and create a hole here in their trachea. We call that a tracheostomy. So the mechanical ventilator is attached to the trachea. Well, the advantage of that is now the patient's mouth is free, so she can talk and she can even swallow and chew food naturally because there's nothing here anymore. But of course, patients are so scared to hear that they have a hole here, so it scares them no end. No? So as far as pulling the plug is concerned, you might say, if the doctor has been taking care of this patient for a long period of time and actually knew that the patient is really terminally ill and dying, they actually discuss what we call advance directives and say that no matter what we do, your disease has progressed to such a point that we will not be able to cure you anymore. And no matter what happens, it's going to end up in death. And therefore, if you reach this point that you're having such a difficult time breathing, instead of artificially making you breathe, we're just going to allow you to pass on as naturally as possible. We're going to give you oxygen by face mask, no intubation, nothing invasive entering through your throat, no, and then we're just going to give you medications to make sure that you just sleep, you're pain-free, and you're going to pass on surrounded by your loved ones, no? And they can pray around you, and we'll call the priest to also give you spiritual care. And that's how we do it in palliative care. So what happens is, in some institutions where there's no palliative care, patients enter the emergency room. They are not asked about their end-of-life preferences. They just intubate the patient without seeking their informed consent about it. They're not able to remove it because really the patient is terminal. And later on, they tell the family members, she's not going to get any better. She's dying. Let's pull the plug. It creates a lot of ethical dilemma to the family because it's like, oh my God, you meant to say I'm going to be the one to kill my own mom or my own dad? Exactly. But in reality, if and when we actually have to stop artificial respiration, since it's a medical procedure, we were the ones who inserted that tube and attached her to the mechanical ventilator. In principle, it should be a doctor who will remove the tube and remove the mechanical ventilator. We don't even ask family members to pull the plug. That's so traumatic to family members. So they're going to remember the end of life of their parents, for example, in such a traumatic manner. So, and therefore, in these particular cases, they're not actually performing euthanasia. If you're talking about a terminally ill, dying patient, you're actually what we call allowing natural death. Because you just delay death artificially. So it's just the machine keeping the person alive.
On their own, they cannot survive anymore.
Yes. But there's really, as long as that's clear that we're not killing anyone, we're just accepting the fact that we can no longer prevent them from dying, and we're just allowing the natural process of death to happen, then it's ethical and there should be no trauma or even pangs of conscience on the part of the doctors and on the part of the family. But there's a lot of misperception about the whole process. Mhm.
Now I realize that it's very difficult to become a doctor because you
Yes.
have to make all of these ethical decisions about your patients.
Correct.
And I'm wondering if there are certain principles that you have to abide by, so that you are sure that you are really making ethical decisions and helping the patients and their families to make ethical decisions as well.
Correct. So the foundation of everything will still be the respect for human life and human dignity. If that is clear, that the person in front of me is a person, not just a patient. Because patient is looking at her from a sick perspective, right? But a person with rights, the right to life, no, the right to good life, good quality of life. Then the four ethical principles that we follow in bioethics would come in, no. So the first would be what we call beneficence. These are Latin terms, English but derived from Latin. Bene meaning good. Ficens came from a verb called facere. In other words, translated into English, that means do good. Okay. So, how do you know you're doing good? Because you're respecting the life of the patient, you're respecting the human dignity of the patient. Then non-maleficence, no, no, and then male is evil. So facere again. So in English, it simply means do no evil or do no harm. Do not burden your patients with futile, risky procedures, painful procedures even. So do good, avoid harm. That's beneficence and non-maleficence. So those are the first two ethical principles. And in fact, it's the highest. No, always going back to respect for life and human dignity. No? Then after that comes the principle of autonomy. Auto meaning self, right? The patient's right to self-determination. I can only determine for myself what is best for me if in the first place the doctors disclosed everything. If we are hiding the truth from you, that's why at the beginning of this discussion, I was highlighting the need for truth-telling on the part of doctors, absolute truthfulness, not necessarily telling the truth at once, but gradually in the doses the patient can accept. No, then with truthfulness, now the patient knows the pros and cons, the benefits and the burdens, the risk, even the cost. They will now come into an informed decision and choose for themselves. I want this, I don't want this. And there's no right and wrong. It's a matter of values and preferences. And many times, even their love and concern for their loved ones come into the picture. No? Because of course, cost is a major determinant in the Philippine setting. And lastly, the principle of justice. No? Giving everyone their due. So meaning, fair. No? You equally distribute the benefits, you equally distribute the burden. Because unfortunately, in the setting of third world, sometimes it's actually the poor, the uneducated, the ones who are marginalized, those in the peripheries, get most of the burden without getting the benefits. So in other words, if you're practicing in a government hospital, for example, even if they have no cent in their pocket, you still will treat them as if you're going to treat the richest person in the Philippines, for example. So it's not like you're going to give this kind of care to the rich person and then any kind of care to a poor person. No, so of course, but the thing is, since everything is out of pocket in the Philippines, it's not actually unethical if a rich person can afford a ventilator and a poor person cannot afford a ventilator. It's not unethical not to even attach them to a ventilator. Because we cannot impoverish the family as well. So even that is part of the equation. It's not the most important, but you have to factor it into the equation in the decision making whether to subject your patients to what we call ordinary means or extraordinary means of life support. The expensive, burdensome, high-tech procedures and equipments fall under extraordinary means, disproportionate means of life support. Whereas the ordinary means of life support, it's simply food and water, the compassionate care for the patient. So those are the ordinary means of life support.
You've been in palliative care for quite some time, Doc, right?
Yes.
And I would like to know, are there memorable cases that you have handled that really sort of burdened you as a doctor because you have to really come up with really ethical issues? Can you share with our students these dilemmas that you have gone through as a doctor in palliative care?
Well, aside from the, because usually the request from euthanasia by definition should come from the patient. And I can recall, because it was a colleague that we took care, whom we took care of. He was a practicing doctor in the provinces, and he was suffering from lung cancer. And then, so he knew his condition. As a doctor, he knows the odds, you might say. So, but since he came in breathless, severely breathless, at the emergency room, they automatically intubated him and attached him to a mechanical ventilator. But obviously, he's not going to get any better, and he knows it. And of course, to be hooked to a mechanical ventilator is no joke. I mean, whether you like it or not, air will be blown into your lungs, and you have to breathe simultaneously with the ventilator, or else you feel like you're going to drown all the more. You feel like you cannot breathe. So you have to practice breathing with the machine, you might say. So it brings with it suffering also. So, and he knows that he will not be able to speak anymore, he will not be able to eat naturally, he will not be able to communicate with his family. So he is asking that we remove the mechanical ventilator. And of course, since he was very lucid, we have to explain to him the pros and cons and what's going to happen if we remove the mechanical ventilator. Bottom line is, he's going to die. No, maybe not immediately after the removal of the ventilator, but maybe a few hours, if not a few days later. He'll be lucky if he'll be alive a week later. And so he knows. And there's really nothing wrong with removing the mechanical ventilator in a patient with very poor prognosis, who is able to decide for himself that this is not the kind of life I want for myself. This is where the autonomy is coming in. But only because he was dying. We would not remove the ventilator if he were not dying. No, that's out of the question. No, so, but it was going to be Christmas. As in, I think the next day was going to be Christmas. So, of course, the wife was crying like anything. The children were crying like anything. Doctora, he really wants to go, and tomorrow will be Christmas. So, I had to talk to the patient again. Doctor, your wife, it's so heartbreaking for them to make this decision that you want to go already, and it's going to be Christmas tomorrow. Like that, can we wait another 24 hours? No, he's not going to get any better. There's no point telling him na maybe tomorrow will be another day that then he'll be better. No. And then he said, Doctor, I'm ready. I have made my peace with God. I have gone for my confession and the last sacraments, and I want to celebrate Christmas in heaven. So he's like, so what? How are you going to answer anybody like that, right? So, and then so we were all crying like anything. Of course, I have to appear brave and very, very composed in front of him like that. No, but actually, I found him very, very brave. And he actually had to sedate him to make the end of life very comfortable for him. But sedate in such a way that he will wake up when you call his name and you tap him like that. Doctor, how are you? Like that. He will say, okay, like that. No. So, and he eventually died peacefully, surrounded by his family. They were all praying around him a few hours later. It was memorable, not because it was unethical, but because it was a very brave decision on his part, and a very brave decision on the part of his family members to support him in that, because unfortunately, the patients could be quite clear about their end-of-life preferences. When the patient is no longer able to speak up for himself and to insist that this is what I want, the family would overturn his wishes, and that is unethical. Because it's the patient's right by autonomy, as long as he's fully competent, in his full possession of his mental faculties, to decide for himself what is right and wrong, as long as the doctors are very, very clear about everything.
Like cases do not resuscitate,
Correct.
right? Uh-huh.
So if the patient is already wanting do not resuscitate, and then when he's near coma or comatose, the family wants all aggressive measures, in reality, we have all the right to dismiss the family's wishes. Unfortunately, we are always threatened. They can sue us. So this is when ethical and legal goes into battle. Because we're not doing anything unethical, but they could sue us. And in reality, nothing will come out of the lawsuit, because we have the patient's written document signed by him that this is the kind of end-of-life care for me.
It's like a waiver that they have to sign.
Yeah. Everything has to be documented, that they really wanted to allow natural death. No more aggressive life-sustaining measures for them.
Wow, that's very interesting. Now, many of the people who will be watching this discussion are students, no, second year students of FEU, and I would like to ask you, what are the pointers or advice that you can give them should they face these ethical dilemmas, especially when they have to deal with dying family members, let's say they are the ones who are pregnant, or they have impregnated someone, because we have been talking about the beginning of life and the end of life issues in bioethics. What are the key points that you would like to impart to our students?
Well, we talked about basic human right? Right to life. But we cannot also forget the fact that why is life so important, no? So ultimately, it's not just that life is valuable, but also the idea that life is sacred. And why is it sacred? Because in the first place, we are not the owners of our life. We are merely stewards of our life. So regardless of religion, usually all of us believe that obviously we did not give our own lives to ourselves, right? We did not create our own life. So somebody higher, bigger, supreme than we are gave us that life, but only to take care of to the best of our ability. No, so and therefore, whenever you're faced with dilemma that will touch on life, you will be accountable not only to the person you are serving, but ultimately to the creator who gave that life to that person, right? So you might say, it's the patient requesting for it, It's his life. Well, he had no right to make that decision because his life was not his. Ultimately, he will have to be accountable to his maker. And if as a doctor, I want what is best for my patient, I want him to be happy, not just here, but happy eternally. And that's how I always discuss it with them. You may be able to get away from the suffering of this life, asking for euthanasia, for example. But there's such a thing as the other life, and it's even the eternal life. And because of your unethical choices here, it will redound to eternal suffering. I think we'd rather suffer here because anyway it's going to end soon and I'm going to make you as comfortable as possible. So it's never to forget that human life is sacred and each of us is so unique that even twins you might even say identical twins are still unique because they're only seemingly identical externally, but when you go at the level of the molecules, they're not. Their genes are not the same. That's why there are differences in the organs and in their genetic code. And ultimately, there are two different souls. If you're a believer, no, there cannot be, you have the souls, right? Maybe in twinning, yeah, the body was half in the process of human development, but there's no such thing as half a soul. No, each person has his own soul. So each and every one is unique and wanted and loved by their maker. So if therefore, even before you were created, you were loved, we as human beings, how can we not love ourselves and how can we not love and other people? So when you respect another person, ultimately, you're admitting the fact that I'm respecting the maker of this person as well. So there's that accountability not only to the person concerned, but ultimately to God. No? So they may not call that supreme being God, but I suppose even the atheist and those practicing natural religion would want to think that there is a better life. All of us dream of a better life, not just here, somewhere, sometime else. Yeah.
And you're right in saying that there are also universal values that
Correct.
are shared across cultures, right?
Correct.
And you usually use these as bases, no, when we make ethical decisions. Because I think the challenge now for young people is that there seems to be extreme moral relativism in our
Correct.
society, that it's my life, it's my body, and all that. And so it becomes a challenge for them when they have to make certain decisions based on these standards, no? Because they make their decisions based on the
Situational
situations.
ethics.
Can you elaborate on that situational ethics that most people follow when they have to make certain decisions.
So in other words, they're banking on their knowledge, value, and preferences. And there's really nothing wrong with that, except that you have to keep that as secondary to a higher measuring stick. No? And the higher measuring stick, the norm of morality, because the conscience, which is all of us have, is the subjective norm of morality. I think this is right for me. I think this is wrong for me. So our conscience tell us that. But even conscience follow what we call an objective norm of morality. And this is the natural moral law. And ultimately, the natural moral law says, do good, avoid evil. And what is good? Respecting life, respecting the dignity of each person, and knowing that your life is simply lent to you. You don't own it. You have to give an accounting of how you lived your life to the one who gave you that life. So then therefore, it's no longer just subjective me, and rather ultimately is what I'm doing in line with what the Creator wanted for me. And you know what? In the end, the Creator only wanted us to be happy. He made us for happiness. He's preparing happiness for us. For as long as we obey His laws. And His laws are not difficult.
Wow, this has been a very enlightening discussion, Doc. I have never realized that there are a lot of things that we have to consider, no, in this field called bioethics. We have medical students here in FEU. We have nursing students as well, those in the medical field. And I would like to ask you if there are specific sets of advice that you would like to impart to our students as far as this issue on bioethics is concerned.
So in the end, it's all about knowing the principles, but more than just knowing is really reflecting on them. And I would say you have to pray about them. Even if I have been practicing medicine for a long time and I am in the field of bioethics, I teach it, we discuss ethical dilemma right and left during the meeting of the bioethics committee, the institutional review board in the hospital. Sometimes you still have to ask for light to be able to remove all your biases and your own feelings into the matter, because sometimes, especially if you've taken care of the patient for a long period of time, you have become close to the patient and the family, it actually breaks your heart to lose a patient even. No, you cannot help but cry inside you whenever you lose a patient. You have to pray. You don't have to rush yourself into a decision here and now, so that in the end, you always consider the patient's best interest. The way we always advise family members and the ethics committee will be, this is not about you. Because sometimes if you put yourself into the equation, then it will complicate matters. This is about a person who has entrusted his own life in your hands, and he has his own value system, and ultimately what he wants is just what's best for him. No, and even if he may die still with some pain and suffering, in the end we console him with the idea that it's not going to be wasted. That pain and suffering would mean less pain and suffering in the other life, right? No, so you might say you're buying eternity with your pain and suffering here and now. No, so and therefore you might say medicine is challenging, medicine and nursing is tiring, and you have to crack your brains literally and figuratively all the time. But as long as you're happy in what you're doing, you're at peace in the care of your patient, and as you help them make those ethical decisions, in the end, it's going to be another day for the whole team, no? They need not suffer from burnout and even guilty consciences, no? So and therefore you need the help of everyone. You cannot do it on your own, no? So among doctors, we help each other, we help the nurses with us, no? And then we guide the students every step of the way, no? So in other words, in ethics we say, if you're in doubt, don't act. Resolve the doubt, consult the experts, read your books, consult the priest, for example, in certain ethical dilemma, or your pastor if you're non-Catholic. And then only if you have a certainty that you have tried to resolve the doubt as best as you can, only then should you act. Because once you have lost a life, you cannot regain that life again. No? So that's why resolve the doubt and then act. No? So that's how we do things in ethics.
Thank you very much, Dr. Manalo. This has been a very enlightening experience for me personally, because I didn't realize that medicine, that the field of medicine is something that really requires individuals and people to make these tough decisions. And you really have to be grounded on a certain set of moral values and standard to be able to surpass all of these challenges in your field. So thank you very much once again. And for our students, just as a recap of what we have discussed, Dr. Manalo has very credibly discussed the 4 principles in bioethics, namely autonomy, justice, beneficence, and non-maleficence, which I think we should study further so that we will have a better appreciation of this discussion. So thank you again, Dr. Manalo, for your very kind accommodation of our request. And thank you to our students for patiently participating in this discussion, and see you again in the next session.
Thank you very much for this opportunity to enlighten everyone, because in the end, all we want is to make sure everybody has a very enjoyable life, happy life, and happy ever after.
All right, thank you.